This conference will now be recorded.
So shall we start the class? So we were dealing with the kidney topic. We had discussed about the anatomy of the kidney. So the major clinical features which are involved in and so what are the causes of the nephritic syndrome? What were the causes of nephrotic syndrome? And individually, we have dealt the immunological injury to the kidney and various types of glomerular nephritis. We have discussed about membranous glomerular nephritis, MPGN, membrane of proliferative glomerular nephritis, focal segmental glomerular nephritis, and minimal change disease. So Alport syndrome, hereditary nephritis, thin basement membrane disease, all these we have discussed in the last class. Now today we are going to discuss that is nephritic syndrome, and when we are discussing the nephritic syndrome, so we will also discuss So we'll discuss the nephritic syndrome, and we'll also discuss what are all the causes, what are all the glomerular nephritis which are associated with nephritic syndrome. So now initially what we're going to discuss is briefly the immunological injuries involved in the kidney, and then later on what is nephritic syndrome, what are the clinical features, and other type of glomerular nephritis which are associated with nephritis, that is post-streptococcal glomerular nephritis as well as rapidly proliferative glomerular nephritis. So, and as I've said before, we'll talk about the mechanism of injury, that is pathogenesis, then electron microscopy, immunofluorescence, all that we will be discussing. So glomerular nephritis. So we already studied that glomerular injury is nothing but immunologically mediated or immunological, and it could be either anti-glomerular basement membrane antibody mediated or immune complex mediated. And the various mechanisms which are involved in these type of glomerular injury, immunological injury, are various complement pathways, that is alternate complement pathway, cell-mediated immunity, and as well as antibody formation. So this we have already discussed. Is immunologically mediated, and due to anti-glomerular basement membrane antibody formation leads to the injury, and sometimes immune complex formation leads to injury. And various mechanisms, that is alternate complement pathway, cell-mediated immunity, and antibody-mediated injury. So all this we have discussed. Now, when you have an antibody, anti-glomerular basement membrane antibody, these antibodies can be against the components of glomerular basement membrane or against the components, in situ component, or you can have a planted antibody. So these are the antibodies. So whatever anti-glomerular basement membrane antibodies are against the components of glomerular basement membrane, or these antibodies can be in situ antibody or antibody which is planted from the circulation. We have discussed extensively, just a brief up, and immune complex deposition. And we have also studied the immune complex can be circulating immune complex which are deposited. And these immune complexes which have antigen and antibody, the antigen can be intrinsic, like in case of systemic lupus erythematosus, or extrinsic due to infection. So immune complexes, that is nothing but antigen and antibody formation. They can be either circulating or in situ. And the antigen here can be either intrinsic, like in systemic lupus erythematosus, or it could be extrinsic, for example, in any kind of infection. Now, we have discussed about nephrotic syndrome and also a little bit about nephritic syndrome. Now, what is nephritic syndrome? So, what you have is an onset which is acute and predominantly hematuria. So what do you understand by hematuria? Red blood cells in the urine and hemoglobin casts in the urine. That is nothing but hematuria. Patient will also have oliguria, azotemia, hypertension. So these terms we have already got familiarized. So what is azotemia? All that we have familiarized. And mild proteinuria. So usually you have massive proteinuria in nephrotic syndrome, but in nephritic syndrome, what you have is a mild proteinuria as well as mild edema. So we have discussed. So hematuria will be there, that is RBCs and hemoglobin cast, azotemia, that is raised. So blood urea nitrogen, next oliguria, hypertension, and here you have mild proteinuria, which differentiates from nephrotic syndrome where you have massive proteinuria and mild edema. So in any common pathogenic pathway, so what do you have within the glomeruli? So within the glomeruli, you have the proliferation of the cells within the glomeruli. You have leukocytic infiltrate. You have injury to the capillary wall and escape of red blood cells in the urine. And hemodynamic changes resulting in reduction in glomerular filtration rate, oliguria, reciprocal fluid retention, renin release resulting in hypertension. So what we have ultimately within the glomeruli, you have proliferation of various cells and with leukocytic infiltrate, and you also have injury to the capillary wall, and due to the injury you have escape of red blood cells. That is why you have hematuria and glomerular nephritis and reduction in the glomerular filtration rate. Apart sorry, apart from that, they have oliguria, fluid retention, and renin release leading to hypertension. So these are the pathological pathway that you observe. That is mainly the proliferation of leukocytic infiltrate in the glomeruli, injury to the capillary wall leading to escape of red blood cells, reduction in the glomerular filtration rate, oliguria, and because of these changes, there is retention of the fluid in the body. So fluid retention and renin release resulting in hypertension. So what are the causes of glomerular nephritis? Very, very important. What are the causes of glomerular nephritis? Acute proliferative, acute proliferative, so you have acute proliferative glomerular nephritis, which are the causes of glomerular nephritis, post-streptococcal glomerular nephritis or excuse me, post-infectious glomerular nephritis. Your other cause is RPGN or rapidly proliferative glomerular nephritis. Sorry. So causes of glomerular nephritis, there can be acute proliferative glomerular nephritis, post-streptococcal or post-infectious glomerular nephritis. You can have rapidly proliferating glomerular nephritis. The morphology here in rapidly proliferating glomerular nephritis on electron microscopy, what do you see here is crescent formation. So which is characteristic of rapidly proliferating glomerular nephritis. The crescents are usually what you have the proliferation of various cells. It can be monocyte proliferation, neutrophilic infiltration, all together they form the crescents in glomeruli, which we will discuss later. And IgA nephropathy or Burgess disease, we have already discussed. So it's also the cause for glomerular nephritis. So the causes of nephritic syndrome. What are the causes of nephritic syndrome? So the acute proliferative glomerular nephritis, post-streptococcal or post-infectious type of glomerular nephritis, rapidly progressive glomerular nephritis or crescentic glomerular nephritis, IgA nephropathy or Burgess disease, hereditary nephritis or Alport syndrome. These are the causes of nephritic syndrome. Secondary causes are nothing but systemic lupus erythematosus. Next is good pasture syndrome. So polyarteritis nodosa, Wegener's granulomatosis, HSP or Hinoish colon purpura, and bacterial endocarditis. So we have dealt with the primary causes of glomerular nephritis. Now, what are the secondary causes of glomerular nephritis? SLE or systemic lupus erythematosus. Next, good pasture syndrome. So polyarteritis nodosa, Wegener's granulomatosis, HSP, Hinoi's colon purpura, and bacterial endocarditis. These also cause nephritic syndrome. Very, very important. So a nephritic syndrome is given. You should be able to write all the type of glomerular nephritis which are involved. So that is primary and secondary causes like SLE, good pasture, SPAN, Wegener's, HSP, and bacterial endocarditis. Now we'll be dealing with each of these. So today we'll be dealing with acute proliferative glomerular nephritis or post-infectious glomerular nephritis. And one more thing is RPGN or rapidly proliferating glomerular nephritis. Now, what is the cause of acute proliferative or diffuse proliferative glomerular nephritis? It is post-streptococcal type or post-infectious non-streptococcal type, caused by immune complexes inciting agents, and exogenous, which is post-infectious, endogenous, which is SLE. So usually this acute proliferative glomerular nephritis, diffuse proliferative glomerular nephritis, the cause is diffuse post-streptococcal infection or post-infectious non-streptococcal type, and usually caused by immune complex inciting antigen. So exogenous agent like post-infectious or endogenous like SLE. So all these cause acute. Mostly it is post-streptococcal, or it could be non-streptococcal type like immune complex which can cause acute proliferative, or it could be post-infectious conditions, and endogenous cause like SLE can cause acute proliferative or diffuse proliferative glomerular nephritis. So post-infectious causes which are causing acute proliferative or diffuse proliferative glomerular nephritis are post-streptococcal, next pneumococcus, staphylococcus, and viral infections like mumps, measles, hepatitis B, and chickenpox. All these are the causes for acute proliferative. So other than streptococcal, it is pneumococcal, next staphylococcal, and viral infections such as mumps, measles, hepatitis B, and chickenpox, which cause post-infectious glomerular nephritis. So pneumococcal, staphylococcal, viral infections like mumps, measles, hepatitis B, and chickenpox, which cause post-infectious glomerular nephritis. Classically, acute proliferative glomerular nephritis associated usually with streptococcal infection. Children, most common in children, associated with the sore throat and skin infection. After 1 to 2 weeks, 4 weeks, so you have the manifestations of oliguria, hematuria, fever, edema, and hypertension. So classically, post-streptococcal glomerular nephritis, more common in children, associated with sore throat and skin infection. So after 1 to 4 weeks. So 1 to 4 weeks are incubation period. So that is followed by oliguria, then hematuria, fever, edema, and hypertension. Oliguria, hematuria, fever, edema, and hypertension. So streptococcal, which is causing this are nothing but group A beta hemolytic streptococci, and only certain strain which are nephrogenic. Other causes are streptococcal. So mainly that is group A beta hemolytic type. So streptococcal, which is usually group A beta hemolytic type. Certain other strains of streptococci are also involved, which are causing damage to the kidney. They are nephrogenic. So usually the streptococci which is involved is here in this condition is group A beta hemolytic type. Certain other strains also involved which are nephrogenic to the kidney. So what happens in the pathogenesis? So when you're talking about any glomerular nephritis, I said what is the mechanism of pathogenesis you should remember. What are the light microscopy findings? So what are the electron microscopic findings and immunofluorescence apart from the clinical feature? Etiology we have discussed for acute proliferative and classical type, that is streptococcal induced. What happens here? It is usually deposition of immune complexes. And immunofluorescence, what do you see? You have granular deposits of IgG and complement. And what you have here, so because of there is hypocomplementemia, since there is deposition of the complements in the kidney within the circulation, you can have hypocomplementemia. And what immune complexes you can see? Circulating immune complexes as well as in situ immune complexes which are deposited in the kidney. So what is the antigen which is responsible? Most common cause is streptococcal antigen. And GBM, what happens to the GBM here? There is alteration in the GBM, and the altered form of IgG immunoglobulin gets deposited. So usually it is immune complex mediated, the pathogenesis. What is the antigen responsible for this immune complex formation? Is streptococcal antigen, against which antibody is formed. And in the immunofluorescence of the kidney, you should see granular deposits of IgG immunoglobulin as well as complement. So the deposition of immunoglobulin, IgG and complement in the granular fashion you have. And in the circulation, you have immune complexes as well as in situ immune complexes which are depositing in the kidney, ultimately leading to hypocomplementemia. So you have altered glomerular basement membrane and altered form of IgG. So what you see grossly, what you see, there is slight enlargement of the kidney. Gross is nothing but the morphology of the kidney. So when you get a kidney, what do you find? There is slight enlargement of the kidney. In light microscopy, in H&E section, what do you see? There is uniform increase in cellularity. Increase in cellularity you see in microscopy. And all the glomeruli, there is diffuse swelling of endothelial cells. Within the glomeruli, there is diffuse swelling of the endothelial cells. So also you can see that there are mesangiation, neutrophils, monocytes. So what inside in the capillary? So what do you see within the morphology? There is kidney, there is enlargement of kidney on light microscopy. So light microscopy, what do you see on routine histopathology? There is increase in cellularity of the glomeruli. And in the cellularity, what do you see? Increase in the cellularity, you have the proliferation of mesangial cells or the supportive cells and inflammatory infiltrate proliferation like neutrophils and monocyte proliferation, and you have thrombi within the capillaries, glomerular capillary thrombi will be formed. And also you can see that is there is swelling within the glomeruli. You have the swelling of endothelial cells, proliferation and swelling of the endothelial cells. So there is increase in cellularity with proliferation of cells like mesangial cells, neutrophils and monocyte, swelling and proliferation of endothelial cells and thrombi in capillary, which you can appreciate on routine histopathology light microscopy. Now in electron microscopy, what do you see? Various kinds of deposits. So the deposits of immune complexes, where all you can see the deposit in post-streptococcal glomerular nephritis, either subendothelially deposits you can appreciate, intramembranous deposits you can appreciate, or subepithelial deposits you can appreciate. And immunofluorescence, we've already discussed it, is granular deposits in case of immunofluorescence of IgG complement. So on electron microscopy, you have immune complex deposition. The immune complex can be deposited either subendothelially or it can be subepithelially in the form of humps or along the basement membrane, that is intramembranous deposit. Immunofluorescence, you have granular deposits of IgG complement. So what do you see? This is light microscopy finding that this is light microscopy, and within the light microscopy, what do you see? There is within the glomeruli, there is increased cellularity of the glomeruli and diffuse proliferation of the cells with increased cellularity. And this cellularity includes monocyte, that is mesangial cells, neutrophils, monocytic proliferation. So all this you can see there is increased cellularity with the proliferation of various cells like so mesangial cells, neutrophils, monocytes, all these are being proliferated within the glomeruli. there is diffuse proliferation with increased cell density. And this is in light microscopy, what you see here. In the electron microscopy, what you see, this is the basement membrane, what you can see here, and the deposit of immune complex is subepithelial. So basement membrane and the deposit here is subepithelial basement membrane. So the deposit subepithelial. So what you see here is the subepithelial deposit, and immune fluorescence, what you see is granular deposition, immune fluorescence, granular deposition of immunoglobulin IgG. So this is immune fluorescence. So you can see that fluorescence here, isn't it? So that there is granular deposition of IgG immunofluorescence. This is in classical acute proliferative glomerular nephritis features. So what do you see here? Already we have discussed clinical course, more common in children. So with post-pharyngitis infection, acute in onset with slight fever, malaise, nausea, oliguria, and azotemia. So what is most important feature here is hematuria. So all these type of glomerular nephritis, that is post-focal RPGN, all these fall under the features of hematuria. So mild hypertension, smoky brown urine, and the patient has mild proteinuria, hypocomplementemia, and what do you have is anti-streptolysin O, increase in anti-streptolysin O. So this is also very, very important. So most commonly you're seeing in children presenting with post-pharyngitis infection, acute onset with fever, malaise, oliguria, azotemia, which we have already discussed, hematuria. So hypertension, smoky brown urine, mild proteinuria, hypocomplementemia, anti-streptolysin O, cases, and 1% of the case only that is progress to rapidly proliferating glomerular nephritis, which usually has bad prognosis, and some become chronic glomerular nephritis. So 1% of the cases go into rapidly proliferative glomerular nephritis, some become chronic glomerular nephritis. Now, what is rapidly proliferating glomerular nephritis or crescentic glomerular nephritis? So, other name is crescentic. So, formation of the crescents, which you can appreciate in the light microscopy. It is a clinico-pathological syndrome. So, rapid and progressive loss of renal function occurs here, and the patient will have severe oliguria. So, death from renal failure. So, it is a devastating condition. So it is very devastating condition, and prognosis is usually very bad. And death from renal failure within weeks to months. Histology is characteristic, which is nothing but crescents in the glomeruli. So rapidly proliferating glomerular nephritis is also called as crescentic glomerular nephritis. It is a clinico-pathological syndrome. What happens here is rapid and progressive. So this condition progresses very rapidly. That's why it is called rapidly progressive, leading to, that is, renal failure. So the patient will have oliguria and death from the renal failure very soon, that is within weeks to months. So why it is called crescentic glomerular nephritis? So microscopically on histopathology, you find crescents in the glomeruli. So any glomerular nephritis, what is the pathogenesis? So the glomerular injury here is immunologically mediated. So immunologically mediated glomerular injury occurs, and there are several diseases within the kidney and systemic diseases which can cause RPGN. So usually the injury here is immunological mediated. So several diseases within the kidney and systemic diseases which can cause glomerular injury. So type 1, type 2, type 3 RPGN are there. So what is type 1 RPGM? Anti-glomerular basement membrane antibody. So anti-GBM antibody mediated injury occurs in case of type 1. Antibody against GBM, glomerular basement membrane in type 1. So the conditions involved are idiopathic and good pasture syndrome. So good pastures and idiopathic. Next, type 2. So it is immune complex mediated. So in case, again, idiopathic and systemic lupus erythematosus causes type 2. Post-infectious causes type 2. HSP or Hinox pollen purpura causes type 2 glomerular nephritis. Next, type 3 glomerulonephritis is usually pauci-immune type and usually mediated in conditions like vaginous granulomatosis, idiopathic, and polyarteritis nodosa. So these are the conditions. So you have in RPGN, mainly it is immunologically mediated. Type 1 is antibody mediated. Antibody against the glomerular basement membrane in conditions such as idiopathic and Good-Pasteur syndrome. Type 2 is immune complex mediated. Immune complex mediated in which condition? Like systemic lupus erythematosus, idiopathic conditions, post-infectious condition, and also HSP or Hinosh pollen cholera. Type 3 is pauci-immune mediated in conditions such as idiopathic, vaginous granulomatosis, and polyarteritis nodosa is type 3. So type 1 or anti-glomerular basement membrane antibody in case of type 1. So what kind of deposits you have here on immunofluorescence? So linear deposits of IgG immunoglobulin and C3 in the glomerular basement membrane. And anti-glomerular basement membrane, whatever are formed, they cross-react with the pulmonary alveoli, similar to that in case of Good-Pasteur syndrome. And here the patient has pulmonary hemorrhages and renal failure, similar to the Good-Pasteur syndrome. So what is the treatment for this condition? So the patient is usually benefited by plasmapheresis and the removal of antibody from this circulation. So type 1, type 2, type 3. So type 1, you know, it is antibody to the glomerular basement membrane. Here you have on immunofluorescence linear deposits of immunoglobulin, IgG immunoglobulin as well as C3 complement on the glomerular basement membrane. Now, whatever antibodies which are formed, that is anti-GBM antibodies, they also cross-react with the lung alveoli or pulmonary alveoli basement membrane, leading to pulmonary hemorrhages and renal failure, similar to in Good-Pasteur syndrome. So the patient is benefited by plasmapheresis, and the treatment is removal of these antibodies, anti-GBM antibody from circulation. Now type 2. So type 2, it is also immune complex mediated and immune complex nephritis. So the causes are post-streptococcal glomerulonephritis like systemic lupus erythematosus. And here you have granular kind of deposits on immunofluorescence. That is lumpy, bumpy kind of deposits on immunofluorescence. So, and type 3. So type 2 is immune complex mediated and immune complex nephritis causes a systemic lupus erythematosus which causes post-streptococcal type of glomerulonephritis. Deposits on immunofluorescence are granular deposits with lumpy, bumpy staining. Next, type 3. Type 3, what you have is pauci-immune, lack of anti-GBM antibodies or immune complexes. So you do the pauci-immune. You do not have antibody formation against glomerular basement membrane like type 1, or you do not have immune complex formation in like type 3. What you have is anti-neutrophilic cytoplasmic antibody formation in the serum or ANCA. So which leads, and this ANCA usually presents with vasculitis, and 50% of the cases it is idiopathic. So type 3 is pauci-immune, not associated with antibody or immune complex. What you have here is antibody against GBM. So what you have here is ANCA or anti-neutrophilic cytoplasmic antibody in serum, similar to that of vaginous granulomatosis. And what you have here is vasculitis, and 50% of cases in idiopathic conditions, you can see this. So what do you see grossly? What do you see in the kidney? Kidney is enlarged and pale, and you have petechial hemorrhages in the kidney. So like microscopy, what do you see? Focal necrosis, thrombosis, endothelial and mesangial proliferation. So and crescent formation. Crescent formation, you have proliferation of parietal cells, monocytes into the bone space. So morphologically, grossly enlargement of the kidney, pale kidney, and you can appreciate petechial hemorrhage. Light microscopy, what do you see? Within the light microscopy, within the glomeruli, you can see that there is thrombosis, endothelial proliferation, mesangial proliferation, and focal necrosis. So light microscopically, you can have necrosis. Next, you can have thrombus formation or thrombosis, which you can appreciate. endothelial proliferation or mesangial. And this RPGN is known for crescent formation. Crescents are formed usually due to parietal cells, monocytes, which proliferate into the Bowman space. So what you can see here is nothing but crescentic formation. So with this is nothing but the glomeruli, and in the this is glomerular capillary loop, and what you can have, so the crescent formation. So in the Bowman space, what you can see here is the crescent formation, and these crescents here also you can appreciate the crescents, and the crescents usually have so monocytes or macrophages and parietal cell proliferation, so which you can see here. So monocytes, macrophages, and parietal cell proliferation in the Bowman space. So this is the glomeruli, and within the Bowman space, so within the Bowman space, so you can see the proliferation of the cells, that is monocytes, macrophages, and parietal in the Bowman space. This is glomeruli hypercellularity in the Bowman space due to the proliferation of monocytes, macrophages, and parietal cells in the Bowman space. This is leading to crescent formation. These are all the crescents that you can appreciate. Now, electron microscopy, you have subepithelial deposits. What are the kind of deposits in RPGN? So you can see that it is subepithelial deposit. So like any nephritic syndrome, whatever is the clinical picture you have similar to that of nephritic syndrome, whatever symptoms you have, which are more pronounced in this particular condition. So the prognosis here, how the patient recovers, depends upon the number of crescents. The more the number of crescents, so that is worse the prognosis. Less the number of crescents, better the prognosis. And what is the therapy here is plasma exchange benefits the patient. So in the electron microscopy, you see that there is subepithelial deposit. So the patient has, that is, so clinical course similar to the nephritic syndrome. Whatever symptoms are there, they're more pronounced, and prognosis depends upon number of crescents. More the presence, better the prognosis. Less the presence, bad the prognosis. So the therapy here is plasma exchange. So with this we finish. So that is nephritic syndrome of the kidney with various causes which are responsible for the nephritic syndrome of the kidney. So we have what are the nephritic syndrome we have discussed. So what are the features of nephritic syndrome we have discussed. So what are the causes of the nephritic syndrome? What are the types of glomerular nephritis? So that is post-streptococcal glomerular nephritis. So what are the causes of post-streptococcal, both streptococcal and non-streptococcal causes of the glomerular nephritis we have discussed. And what are the findings, causes as well as findings of post-streptococcal diffuse proliferative glomerular nephritis. So what are the classical features of post-streptococcal we have discussed on light microscopy, electron microscopy, immunofluorescence. We have also seen the pictures. Then we have discussed about RPGN or rapidly proliferative glomerular nephritis or crescentic glomerular nephritis, the three types and their causes, and what are the main pathogenesis which are involved in the three causes. So what are etiological factors in the three causes? What are the light microscopic finding? What are the electron microscopic finding? What is the treatment aspect of RPGN, that is plasmapheresis? So all that we have discussed. Then we have also discussed the clinical features of these conditions. So in detail, light electron microscopy, immunofluorescence, clinical features of all these conditions we have discussed, apart from electron microscopic finding. So here we finish all the types of glomerular nephritis. Nephrotic syndrome we have finished. Nephritic syndrome, what are the causes here? All the type of glomerular nephritis, pathogenesis of injury to the glomeruli we have discussed, that is immunological, how it all occurs, mechanisms, what are the main clinical features of the kidney, what is all that we have discussed, anatomy of the Bowman's capsule and anatomy of the glomeruli, everything we have finished. Now next class we will be discussing briefly about chronic glomerular nephritis. So major part of the kidney we have finished. So next class we'll be discussing about chronic glomerular nephritis. So what are the microscopic finding? What is the clinical features and morphology in chronic glomerular nephritis we will discuss. And apart from that, the important condition that is RCC or renal cell carcinoma. So you have a you have a slide for RCC, that is renal cell carcinoma slide, as well as you have what is called as a kidney morphology of the kidney of renal cell carcinoma, which is also an important question. So that is kidney tumors and renal cell carcinoma. So that we will be discussing in the next class. So with that, we finish the kidney chapter in total. So we have dealt with all the questions in the kidney. So RCC and chronic glomerular nephritis. So we'll be finishing in the next class. So major topics of the kidney and kidney chapter will be finished. So thank you so much. Any doubts, you can send me WhatsApp or anything. We will discuss in detail. Okay, thank you so much.